Acute bronchiolitis, how to treat and what are the underlying cause. It is less than under 1 year disease. Rarely is being reported above 2 years. Most commonly caused by the respiratory syncytial virus in 50% of cases. Other viruses are human metapneumovirus, parainfluenza, influenza, adeno, rhino, and others, even the entero and corona. So presentation is wheezing, rhonchi, and dominant crackles and prolonged respiratory rate and the fast breathing. So fever, less feeding, the apnea rarely is possible. Hypoxia with nasal flaring, with increased walk of respiratory, all are possible. Even complete bronchial obstruction with diminished air entry in the lung fields, they are also described. So even death in less than 1% of cases by respiratory failure, severe dehydration, dyselectrolytemia, they are also possible. So differentially, certainly you have to think pneumonia, asthma, the vascular ring, tracheo and bronchomalacia, congenital cyst malformations, cystic fibrosis or other ciliary dyskinesia, and even the heart failure and eosinophilic granulomatous, other rare diseases. So, how do you treat? Debate over here is not ever going to be finished, because the most of the text says nothing apart from the supportive case. Even the antibiotic, no, it's not that useful in the bronchiolitis, but this pneumonia is life-saving. And then if you do not investigate and treat on that line, whether you are losing a good amount of children diagnosed bronchiolitis on clinical basis. RSV, RNA, and then other viruses, RNA or DNA, they are not that common practice globally. Then how do you diagnose? At least in severe cases, we know that case fatality in pneumonia is very high. So, and heart failure, you are dealing with again grave disease, uncommon disease, other differentials. They are also needed to be excluded. So thereby, it's an important issue to talk how often you have secondary bacterial infection in the in acute bronchiolitis, and the CBC, chest X, they are all forbidden. CRP and other inflammatory markers, they are all forbidden. How good often they are in almost the investigationless society, and how to treat. So hypoxia, oxygen delivery, ventilator support, they are the late stage treatment of the treatment of the later part. Initial part in how to treat the bronchodilator. Even this is a question. So the textbook view is give antiviral with some benefit, ribavirin and so forth, but to confirm you need some investigations, you need some time. Also textbook version is the monoclonal antibody, nisibimib, 2 doses. They are useful even in the maternal, the 1 dose of then useful in the pre-fusion F protein can be useful in some cases. It takes care of the RSV infection, the respiratory syncytial viral prevention in the early infancy. So if you go on thinking on that line, are you really missing, losing the diagnosis and missing the patients in children under 1 year is a big issue. Thereby, it is important to know support to the global healers, your global researchers, and then really they should think of this part before embarking into the theoretical sort of things in the text and literature.